Okay. Good evening, everyone. Welcome to another virtual shadowing session. We have with us today Dr. Amy Patel. She's a breast radiologist who has taken the time with us to speak about her experiences in the medical field. Before we start, I want to remind everybody, like I do every session, to put any questions that they have in the chat, whether it be in the Zoom or YouTube Live, so that we can go over them after the presentation. Also, please keep your cameras off and yourselves muted. And remember that there will be a quiz posted in our Instagram bio after the session, and you need to get a 75 or higher to get credit. That's about it. You have the floor, Dr. Patel.
All right, thank you. Well, thank you for having me today. I am going to talk about what I do as a breast radiologist and a little bit about me, and then I will leave plenty of time for Q&A. Okay, so I'm a breast radiologist and I'm medical director of the Women's Imaging Center at Liberty Hospital, which is in the Kansas City, Missouri area. I'm an assistant professor of radiology at the University of Missouri, Kansas City School of Medicine. Okay, so a little bit about me. So I, initially grew up in rural Missouri. I did all of my training in the Midwest. I did the 6-year med program at the University of Missouri, Kansas City School of Medicine. So if you have any questions about that later on, please feel free to ask. After that, I did my intern year in internal medicine at the University of Missouri, Kansas City. I did my diagnostic radiology residency at the University of Kansas in Wichita. And then I did my breast imaging fellowship, which is a 1-year fellowship at Washington University in St. Louis. So did the 6-year med program, 1 year intern year, 4 years of radiology residency, and 1 year of breast imaging fellowship. So then after that, I was just sort of wondering, where was I going to go? So this is a group of us, my attendings, some co-fellows at WashU in St. Louis here. The technologists had really, really good training at WashU for breast. And so I decided that, I wanted to start out my career in pure academics and get out of the Midwest to just sort of see what was out there. So I started at Beth Israel Deaconess Medical Center in Boston, Massachusetts. So I was on faculty at Harvard, and it was great. But something was missing. I felt really restless. I had this thirst for leadership, and oftentimes when you're in a more sort of Ivy League sort of institution, it can be hard to ascend the leadership ladder very quickly. It's a pretty hierarchical institution, whether you're at Harvard or Yale or any of the Ivies. And serving in the area in which I was raised really weighed heavily on me. I knew that, in Missouri, particularly in sort of this Kansas City, Northwest Missouri area, there's such a lack of subspecialists for breast. Whereas in Boston, it's like you turn every corner and there's a breast specialist. So I felt sort of like maybe I need to go back and help the area. And then I'm really into and passionate about political advocacy when it comes to patients receiving fair radiological care. And I felt like being in that Harvard system, being able to carry out my advocacy efforts was difficult. There's a lot of restrictions again with these sorts of institutions for what you can and cannot do. So my zeal for advocacy felt pretty stifled. And my support system was gone. All my close family friends were in the Midwest. So that was really tough for me too. So, what I ended up doing is in 2018, a really great opportunity happened for me to go back to the area to practice in the Kansas City area and take over and build the breast program at Liberty Hospital. And then I was soon involved with University of Missouri, Kansas City, yet again as an assistant professor. So I'm involved with the radiology residency program. I teach a class at the School of Medicine called Fundamentals to the 2nd-year med students. I'm faculty advisor for the American Medical Women's Association, our medical student chapter at UMKC, faculty advisor for our radiology interest group for medical students. So I really got immersed quickly, and it's been really fantastic. I've also got to do some pretty cool things with this job. So I'm very much into, not just political advocacy, but community outreach, and particularly educating the public on issues such as annual screening mammography beginning at age 40, getting that screening mammogram. Early detection saves lives. So I've been able to do some really unique things to get the word out. So I was the honorary team captain for the Harlem Globetrotters when they were in Kansas City. So that was a really cool experience. And we got to make a plug for, make sure you get your annual screening mammography at 40, saves the most lives. I have a really amazing team. These are some of the team members for my breast center: technologists, nurse navigators. This was us at the Making Strides Against Breast Cancer Walk with American Cancer Society a few years ago. Also, doing a lot of education with our technologists in the rural areas. Been really fortunate to do that. And then I've been able to do some really cool things in terms of working on legislation in Missouri to pass bills for 3D mammography coverage, for bills for women who are high risk for breast cancer and need coverage for more heightened surveillance, and keeping with the American College of Radiology recommendations for above average risk women. So that bill we were able to pass last year. This was with the efforts of Senator Lauren Arthur in this pink jacket. We worked on the legislation and testified in Jeff City before the pandemic happened and shut everything down. And then we were, by some sort of miracle, able to get that passed, even though there was the pandemic. We've been able to do some really cool stuff with social media with our hospital, which that has another huge interest of mine: healthcare social media. So that's been really, really fun to play with, which was really difficult to get done in the Harvard system. I am doing a lot of community outreach, like I said. This is pre-pandemic, obviously, but speaking at churches, particularly churches of people of color, getting the word out about, again, the importance of screening mammography and saving lives. We know we still have a lot of work to do to close the gap to healthcare inequities and getting particularly women of color in the door to get their mammograms. And same for rural areas. So this is me speaking at an event in a rural area on the right. Any way I can get the word out, I'm on radio shows a lot, podcasts, things of that nature. Again, my goal is to educate as many as I can, because there are, unfortunately, a lot of misconceptions, misinformation, and disinformation out there, particularly in this part of the country. So if I can, help debunk any sort of misconceptions, I try to take those opportunities on. I don't know, this might be well before your time. You may not know who these people are, but this is Boyz II Men, who were a huge R&B group in the 90s, super popular, one of my favorites. And they performed at Susan G. Komen's Rock the Ribbon a few years ago, and I got to meet them, and it was really, really cool. I totally fangirled out. I was on, like I said, I do radio shows, podcasts, TV shows. This was me on the Better Kansas City program. So again, any way I can get out the word about what, the importance of early detection, screening mammography, 3D mammography, I try to get out there. Again, I'd like to do a lot of things in the community for activism and our patients. So this was a fundraiser for Susan G. Komen called the Bigwigs, and I ended up being the biggest bigwig winner because I raised the most money. So I had to wear a pink wig, and it was pretty cool. It was just a really neat thing to do with the community and get our patients involved and things like that. I've been on a billboard for one of our hospitals that we are also affiliated with. So I was on this billboard in Northwest Missouri, and the billboard says early detection saves lives, and 3D mammography. I got to throw the first pitch at a Royals game, which was a dream come true because I'm a huge Kansas City Royals fan. That was at Susan G. Komen Day at the K. I was just so elated. And then now an endeavor I'm doing is I just launched a website, and it's and on the one of the main pages, you know, my whole emphasis is take charge of your breast health. And so my goal of this website, again, is to educate and empower patients. I have a hashtag AskAmyMD. And again, my goals are to educate patients, debunk myths, and be of assistance in any way I can. And, you know, again, you know, just from political advocacy efforts, I've been featured in the Kansas City Star. So some really, really incredible opportunities have come my way from working in this setting. But I have no regrets. I've met some incredible people along the way. My trainees in Boston were awesome. You know, medicine is small. So for those of you who go into medicine, it's important to remember that and not to burn bridges, and to always leave with grace and gratitude, because medicine's small and people definitely talk. Okay, so switching gears a little bit. So as a breast radiologist, what do I interpret? So I interpret 2D and 3D mammograms. I interpret breast MRI, and I interpret breast ultrasound. So 2D mammograms, for those of you who may not know, these are mammograms that are static images. So you have your conventional 4 views, CC, and MLO views, craniocaudal and medial lateral oblique, and just static images. Whereas with 3D mammography, particularly screening with the 4 views, basically with 3D mammo, you're scrolling through images at 1 millimeter slices. So think about like you're turning the pages of a book. That is what a 3D mammogram is like. You're able to really dissect the layers of a breast. And as you can, you know, surmise, because you can do that, you're more likely to detect a tiny cancer that'll be more conspicuous to one's eye, rather than a static 2D mammogram where you may miss that entirely. So screening mammograms are just 4 views. When you see something on a screening mammogram, you call a patient back. It's called a callback. If you see something suspicious that needs further evaluation, and then those are called diagnostic mammograms. So bread and butter of what we do. Breast MRI is something that we use kind of more for advanced testing. So if a patient has a known breast cancer from mammo and ultrasound and biopsy, then oftentimes we do a breast MRI to determine extent of disease. We also do breast MRIs in patients who are high risk for breast cancer, and we want alternating mammo and MRI every 6 months, or a woman with dense breast tissue, which is a risk factor for breast cancer. So this is an MRI here showing a cancer here in the left breast, all of this area that's sort of enhancing or lighting up. And then breast ultrasound, that is our bread and butter as well. Oftentimes, if we see something on mammo, they go to ultrasound. We try to find the correlate. If it needs biopsy, such as this mass here that looks like a breast cancer, you have this really irregular mass here that has some blood flow to it. Then you can biopsy it under ultrasound guidance, which is a much easier way to biopsy something for a patient. So what's really cool about my field is not only do I interpret imaging, but I perform procedures too. I like doing procedures. So mammography guided biopsy, the fancy term for that, or the technical term, is a stereotactic core needle biopsy. I perform ultrasound guided core needle biopsies. Again, those are the sort of the bread and butter of our practice. MRI guided core needle biopsies are more advanced. We do those in the setting of if you see something on MRI and you're not confident you'll find it on ultrasound, then oftentimes we'll do an MRI guided biopsy. And then finally, wire localizations are performed. So if you biopsy something, it comes back positive for a breast cancer or a high-risk lesion and it needs to be surgically excised, we can put a wire in the breast under mammography guidance, which is what I'm showing you here. This is the wire localizing the cancer here, which is this dense oblong thing here. We can locate under ultrasound or even MRI so that the surgeon knows exactly where to go to take the area out. These days now, too, in addition to wire lokes, we place what are called radioactive seeds, which do the same thing as well. So a lot of really cool procedures that currently exist in breast imaging and are coming down the pike as well. So what's a typical day like for me? I think it's pretty awesome. I have a pretty good work-life balance. The job starts around 8. I finish around 4-ish typically. Tonight I was late. I apologize. I had actually a hospital admin meeting, so that's what delayed me. But my work hours on it typically are comparable to those sort of in the normal world. It's really great for raising a family as a result. So with breast imaging, you can take anywhere from minimal call to no call to screening mammography call only. Some practices, depending on practice type, you might take some general call. I am in a practice where I take no call, work no weekends or holidays. So again, I have a really good sort of normal work hour job. Again, the call will vary per practice and institution. And then as far as my service, it's sort of mixed. I'll do in the day a mix of screening mammograms, diagnostic mammo and ultrasound, biopsies of various modalities. But in some institutions, you might just be like on screening mammo in the morning and breast MRI in the afternoon, where that's all you're reading. So it just varies per practice again. We have lots of patient interaction. I think that's a huge misconception in radiology that we don't talk to patients. In breast imaging, we talk to patients all the time, whether you're recommending a biopsy and you need to talk to them about it, whether you are performing a biopsy, you're talking to patients quite a bit. And then in our practice, if the patient has a biopsy and it comes back positive, we do, the radiologists do call the patients themselves to give the news. So, or bring them in and talk to them in the consult rooms. So again, lots of patient interaction in breast imaging. It's really, really great. As far as teaching goes, you can have no teachings, like if you're in private practice or you're in a teleradiology setting, or you could be anywhere from teaching residents, medical students, fellows, depending on the institution you're at. So you really can pick the practice of your choice depending on what you like to do. If you don't like to do any teaching at all, then private practice is probably for you, or telerad. If you actually like to engage with learners, then being at an institution where you can do that's probably for you. And teaching can be at the workstation, like if I was going over imaging with somebody, or through dedicated scheduled lectures and conferences. So there's lots of ways to educate learners. Obviously, as you all know, this is a very cool way to educate yourselves in the virtual space. Okay, I'm going to shift gears again. I thought this might be cool to share with you guys. One really innovative cutting edge thing that we're doing at our hospital and in our breast program. So we have started dabbling with artificial intelligence breast ultrasound. We're the first practice in Kansas City to offer AI breast ultrasound. I wanted to share a little bit about our experience. So I have no relevant disclosures to this. So breast radiology and AI, I really do think it is the future. Many of us feel that AI is not going to replace us as breast radiologists, but AI will make us better at what we do. We are encountering a field of rising imaging volumes, fatigue, burnout, and so AI can really help us mitigate and help in these situations. The current breast imaging AI focus, it varies, but mammography and breast ultrasound are some two really hot areas. So we're going to go over how AI integration can improve practice efficiency and patient care, particularly with breast ultrasound lesions. So every day in the US, physicians order over 4,000 breast biopsies and 80% are benign. So a huge percent are benign. And over 350 cancers still are missed daily, even though we are biopsying so much. And there's 130,000 false negatives each year. So radiologists with comparable training and experience disagreed with each other 25% of the time by deeming different diagnoses. And when presented with the same case a month later, they disagreed with themselves almost 20% of the time. So AI breast ultrasound is a decision support tool, okay? It's based on a machine learning algorithm that is based on more than 400,000 exams with ultrasound and pathologic correlation. Now, the algorithms analyze over 17,000 features per region of interest, and then it renders a risk assessment that's aligned to our BI-RADS, which BI-RADS is our breast imaging reporting lexicon. It's basically the bread and butter of breast imaging. We have very standardized reporting, and we have it standardized through BI-RADS. And this AI breast ultrasound tool is now FDA cleared. So how does it work for the radiologist? Well, we launch the patient case in the AI software. Then the AI software will display images from PACS, which is our system that we essentially, house our images and view the images. And then the radiologist requests the AI software tool analysis on the lesion of interest, and then analyzes the images. The AI software will analyze the images at the pixel level in seconds and captures the BI-RADS descriptor automatically. And then it displays the results and findings that align with the BI-RADS categories. And then we, as the radiologists, can save the findings as a secondary capture to PACS and or export the findings to our reporting system. So this is an example here. Basically, if I wanted to launch a case, I would go in and launch it from my PACS system, and then I would get the image up in 2 planes, so transverse and sagittal. Here, I would click on the region of interest, or ROI. I would click on the mass here and here, which automatically populates a square. You can also adjust the square too, but you want basically a tight box around the mass in each plane to really analyze it properly. And then before, when you analyze, it'll say analyze here. So you click analyze, and then it'll give an assessment. So here I already clicked analyze, and it's saying this mass is probably benign, meaning it has less than a 2% chance of being cancer. So you feel confident knowing that it's okay to continue to follow this rather than biopsy and make the patient go through an unnecessary biopsy. So in the field, in terms of quality improvement, we are finding greater accuracy, lower variability, and improved consistency, fewer false positives, which is really fantastic, fewer false negatives. We are reducing avoidable follow-ups and biopsies, and we're reducing our interpretation time of, approximately by 49%. So that's been really, really huge for a very, very busy practice such as ours, especially, if you think about the number of cases you can do a day. If your interpretation time is reduced, you're able to squeeze in more cases. So as far as the technical configurations, I won't get too much in the weeds of this, but our IT team worked really closely with the AI vendor to make sure that the security requirements were in place, that no PHI, patient health information, left the hospital network. We embedded it with the hospital workflow by analyzing our ultrasound scanner and our PACS-based image data, and then delivered the findings back and make them exportable to our reporting systems, as I previously discussed. So where have we found value? Time saved per case has varied anywhere from 10 to 120 seconds. Particularly for masses that we're not sure if we want to call them completely benign, which is the BI-RADS 2, probably benign, or recommend a biopsy, low suspicion for A. It's helped in that kind of vague categories. Diagnostic case throughput and volume, we've able to increase patient and physician waiting times has been reduced, which is great. The patient waiting less time for the result, physicians getting their reports faster, the referring provider who sent the patient, the diagnostic confidence of the radiologist has been even more solidified. Again, I stress that this is a clinical decision support tool. At the end of the day, we as the radiologists are making the call, but this clinical decision support tool kind of helps give sort of that peace of mind and that diagnostic confidence, like that the hunch or the pretest probability we already had has been confirmed. And then the potential reduction for physician stress and burnout has also been fantastic as well. All right, so that's what I have. I will turn my camera back on, and if anyone has any questions, and also after the talk today, here's my email address, and then my Twitter and Instagram handles are at Amy K. Patel as well. So Okay. Okay.
Thank you so much for that wonderful presentation. Doesn't look like we have any questions yet, but I do have a few. So you mentioned how you went through a 6-year medical program at University of Missouri.
Mhm.
So I've heard a lot about 7 and 8-year programs, and I've heard that even those feel very accelerated. So how did it feel going through a 6-year program, which must be even more?
I mean, it's pretty intense. I think if you do a lot of, if you go to a high school where there's a lot of like AP credits and credits that can transfer over, it helps you a lot, particularly in a 6-year program. So you're not basically like starting from scratch. So it is intense, but I think if you do a lot of legwork, particularly in high school, or you can take some like college classes in the summer when you're in high school, it really lessens the load when you start a 6-year program. At UMKC, you also have the option to extend to 7 years. So some people will do that to sort of just kind of stretch it out a little bit more. But I would say, if you have the opportunities to get some of those prerequisites out of the way in high school, it makes the transition into a program like that, like an accelerated program, way easier.
Okay. Is it a trimester like schedule or is it semester?
It is a semester schedule, but with the 6-year program, you go like all year round. So you'll get like a vacation month, and then you'll also get like uh, typically a vacation month once you hit. I can't remember which year exactly when it starts to be vacation month, but like initially, like your first 2 years of med school or the 6-year program, you're basically like knocking out your undergrad classes and stuff like that. So you're sort of on the same vacation schedule as like just normal undergrad students. So like you get like, your spring break and your Christmas break and things like that. But then once you are past those first 2 years, I believe, then you sort of go all year round and you get what's called a vacation month. And so you have your time during the month.
Okay, that makes a lot of sense. Um, Also, so is there anything that you wish you knew as like a high school student going into the medical field, like something that you could have prepared more or just in
Yeah, I
general?
mean, I think the biggest advice that I could give is that what I just told you about, I wish I would have taken more maybe classes in high school, community college during the summer of high school, so I could really transfer all of those and so it would be easier those first couple semesters. But I went to a high school in sort of a rural area, so we didn't have a lot of opportunities. But even then, if I would have known, like maybe you need to go to like a community college and take some classes during the summer, I probably should have. But I was so busy with other extracurricular activities, I didn't even like really think about it. So that's like probably the biggest regret I have is not preparing myself, like getting those prereqs out of the way really early so that it would have made the transition into an accelerated program easier.
Um, do you have any particularly memorable patient encounters that you'd be willing to share?
Yeah, I mean, I'm trying to think. There have been so many like amazing things that have happened. I think like what we do as breast imagers can be tough because there can be days where you're calling patients with pretty bad diagnoses, and breast cancer is always scary. But I think that um sometimes the stories are really good, especially I have this patient who very, very healthy patient. She's a marathon runner. She was really young, but she was feeling a lump, and unfortunately it did come back positive for a breast cancer, which completely threw her off and completely shell shocked her, and now she's on the other side of it. And I remember that first sort of follow up after her treatment and all of that, and seeing her and just how elated she was getting that clean bill of health. I think is just really, really gratifying. And I experienced this a lot with a lot of our other patients too. So, but that one really sticks out in my mind because it really threw her off. She's a really successful businesswoman. She's a mother of young children. It really spooked her. And then for her to be able to, she likes to call herself a cancer conqueror, to really see her sort of grow through the experience and beat it was really, really inspiring.
Building off of that, so I bet giving bad news is a very large part of your daily like your daily schedule. So how have you learned to sort of deal with the like giving bad news to patients?
Yeah, I mean, I think that I started to really learn how to give bad news when I was a fellow, because in your breast imaging fellowship, you're talking to a lot of patients, you're, really getting comfortable with it. I think that medical schools do expose you a little bit about like how to, give bad news, and they do training on it. But I really think that for breast, it's very sensitive, a very different kind of discussion. And so, the more you do it, the better you get at it. So I think that fellowship has really helped me navigate difficult discussions and talking to patients. But each patient reacts differently. You have to be prepared for that. And again, it just gets better over time. I think I'm still learning, even when I encounter situations where I'm like, whoa, I did not expect that to go there. I think you're just constantly learning as a physician, and it comes with time. So
Okay. It doesn't look like we have any other questions from any of the other members. So I think that's a good place to conclude the session. Thank you all so much for joining, and thank you so much, Dr. Patel, for giving this amazing presentation.
absolutely, thanks for having me. And again, if you need